Good morning, everybody. You've heard the extremely high-tech talks, and you're going to hear the extremely low-tech talk, but this is achievable and doable. Before I get started, I have to remind you all, we have the General Thoracic Dance Club, which will be performing tonight. Those of you who want to participate, we're going to practice right outside these doors at 1 o'clock after lunch. It's going to be a lot of fun, so come join us, and you get a free bandana if you join us. So thanks to Dr. Allen and the Executive Board of the General Thoracic Club for inviting me to speak. This is the best meeting of the year. I love this meeting, and I'm so happy to be here speaking. So I'm going to be going through, I have no disclosures, I'm going to be going through the who, what, where, when, how, and why of enhanced recovery programs in thoracic surgery, but not quite in that order. And this is all about the program I started at University of Virginia, and I'm mostly reporting our first year of results. And I want to emphasize it's only the beginning. It was the first year. We're now coming up on our second year, and it's an evolving process, but this is what we were able to do in that short time. So enhanced recovery is a well-known phenomenon in other surgical specialties, and the basic principles are minimizing stress and the physiologic response to stress, setting expectations and guiding the patient through their surgical journey, and helping the patient feel more like a person rather than a patient as soon as possible. Enhanced recovery programs interface with each phase of care throughout the patient's hospital journey, and it has a lot of focus on teaching and managing of expectations. And it represents a systemic culture change throughout the institution, and for that reason, in fact, it's incredibly difficult to randomize these interventions because everybody involved is aware, and you can't forget that the patient's on ERAS or not on ERAS. It involves providers from both surgery, anesthesia, and nursing, and it uses strategies to avoid fluid overload and minimize the use of opioid pain medications. And we have some unique challenges in thoracic surgery, as Dr. Nonheim so eloquently pointed out this morning. When you have a big tumor, you got to make a big incision. If you search what is the most painful incision, thoracotomy wins, and it's the Achilles heel of our specialty. And then now we have the opioid crisis. And frankly, when we started our program, this wasn't really on our radar, but it is on our radar now. And the NIH is calling for all hands on deck to deal with the opioid crisis. It's the second leading cause of accidental death in this country. And there's a major contribution to this epidemic from surgical patients, so we actually are responsible here in this room for this problem. And in fact, over half of the inappropriate use of opioid medications is from friends and family members of our patients, that their prescriptions are sitting around at home and they start using those drugs. Less than 4% of the opioid use that's illicit is from drug dealers. It's from us. So we have to do something about it. This is a picture here that went viral of a toddler in the backseat of his car while his parents are passed out in the front seat. This is a major, major societal problem. And it's a major focus now of the CDC, of the American College of Surgeons, the Surgeon General. Basically, every major organization is starting to pay attention. And I'll remind you again, the STS is on board with this now. We have the opioid survey that several of us helped develop, and we need that information to figure out how we as a society can make a difference. So you could say, well, okay, all surgery causes pain. But when you look at major elective operations, the rate of opioid use in previously naive patients who have an operation and you find that they're still taking opioids 3 months later, about 3 to 6% of patients fall into that category. But when you look at which procedures are causing the problem, it's led by thoracotomy. There's a 2.5-fold increased use of opioid dependence after thoracotomy. And guess what? The second leading cause is VATS. We all think VATS is so great and minimally invasive. It's the second worst offender of causing chronic pain, opioid dependence. And then there was a paper at the STS looking at this within the Michigan population, and they said 14% of patients are still taking narcotics at 90 days, and they likened it to atrial fibrillation. We consent our patients about AFib as a risk after surgery. We probably should be consenting them about this problem as well. So when we started our program, we wanted to know about pain control. That was an issue, but we also wanted to know other things that we all care about, like length of stay, complication rates, how could we streamline care and do a better job with our patients. And again, low-tech, low-hanging fruit problems we all face every day. So I'm going to tell you about who we did this for. We wanted to have a focus when we started our program, so we specifically chose to do it for our elective pleural, pulmonary, and mediastinal cases, and we thought that there would be a big difference between the VATS patients and the open patients, so we specifically tracked our results differently for those groups and had some slightly different interventions for those groups. So what did we do? Well, we started with, I'm going to review our pathway, and I'll tell you what we did and how we measured it. We started out with how we got our patients ready for surgery. So there was a preoperative teaching phase about managing expectations. We went through what they should expect throughout their hospital stay, gave them things to do to prepare, reduce infections, things like that. And then we gave them these checklists that showed them what should be happening each day of their hospital stay, and then they could feel like they were part of the recovery process and check off what they were doing at each step of the way. We also had this, we created a website and had access to the website in addition to the binders, depending on what was easier for the patients. And we actually now have ERAS programs in quite a few disciplines. On the day of surgery, when they arrived, they would drink 20 ounces of Gatorade, and then they would take Celebrex, gabapentin, and Tylenol before they went into the operating room. When they got to the operating room, we had these laminated cards from our anesthesia provider so that they would know specifically what they're supposed to do for our ERAS patients, because they're covering all different cases. We wanted to make sure they knew what was important for our cases. And we focused on things like protected lung ventilation and minimizing opioid use in the operating room. And in fact, the residents were not allowed to give any narcotics without approval of their attending during the case. And another thing that we did was quite different, was we really rethought our pain management strategy perioperatively. And we all know that epidurals are not perfect, and they fail 13 to 30% of the time. And sometimes they fail the day after, they fall out, they have all these arterial lines, Foley catheters, all this other stuff. It makes the patient look like an octopus with all these tubes coming out of them, and I wanted to get rid of them. And not to mention, they take a lot of time to be placed. And I know they say, oh, it takes 5 minutes, but we all know it can take an hour of OR time to get the epidural in. So that was a big goal of mine, to get rid of the epidurals. And so we have those. We've tried elastomeric pain pumps, which I think don't really work too well. There's data to show that it doesn't help. And then there's rib blocks, and I did rib blocks before, but they last about 6 hours, and it's just not adequate by itself for most procedures. So the biggest change we did with our ERAS program is we got rid of the epidurals, and it did take me about 2 months to do it. I was the new kid on the block. Our program had started 7 days after I arrived at UVA. I couldn't change everything at once, but we started what I like to call surgeon-controlled analgesia, and we used Exparel, which I think a lot of you are using now. Those of you who aren't familiar with it, it's a liposomal bupivacaine. You can dilute it to really large volumes, and I'm learning that the bigger volume we dilute it to, the better it works because it disperses better. So I now just dilute it to about 80 cc's for thoracotomies and about 40 cc's for VATS. It's really important to inject this at the beginning of the case, and I've seen, as my colleagues adopt this, everyone's done it a little differently, and we see a big difference if you do it right at the beginning versus if you wait till the end, because it takes at least 45 minutes to work. And then you have to use it within 4 hours of opening the vial. Not a big deal, but you just have to know that. And you can't use it for obstetrical blocks, not a problem for this audience. And then you should be careful about using it if they have any liver dysfunction, because it's metabolized in the liver. It lasts about 72 to 96 hours. And it costs about $200 to $300 per vial, depending on your hospital contract, and what your hospital charges for it can vary quite a bit, but that's what it costs for the hospital. And I want to say, too, that this is the only thing on the market now, but there are other agents that I think are in development. So it will be good to have some competition in this space and hopefully lower the cost. And my adoption of this, really, I have to give credit to the MD Anderson group. They were the first to publish on this, and they published on how to inject this 4 to 5 centimeters lateral to the spine. For the purposes of demonstration, they put methylene blue in the injectate so you can see where it's going, but I think it works best to inject it transcutaneously. Then you don't get a little fountain of drug spitting out of the pleura when you go transpleurally. So that was something that we started doing. Post-operatively, some of the things that we do, we had early initiation of diet. We stopped fluids early the first morning. It was an automatic order, so you didn't have to remember to turn down the fluids. We had patients out of bed the first day of surgery, and we started tracking how well we were doing that. We had standing orders for Tylenol, gabapentin, and Celebrex, and then just PRN, oxycodone, 5 milligrams. And then we used ketamine infusions for 24 to 48 hours for our thoracotomy patients, and we actually found that it took some while to get used to it, but it has really helped. And then we only used a PCA pump if we absolutely had to, and we reserved it as the last resort. The other thing we did is we tried to streamline our chest tube management, and I have to credit Surf with this. He's been a proponent of this for a long time. But we use the no A, no B, no C rule. No air leak, no blood, no chyle. Doesn't care how much is coming out, you pull the tube. We know that this is a driver of length of stay, and it's a driver of pain. So, and that has probably been the hardest culture change, is to get everyone on our group, all the residents, to adjust to this. We're not there yet. It's not perfect, but we're getting there. Some other things that we've done in the last 6 months since I put the paper together that I presented at the Southern meeting, we've really focused on standardizing our discharge medications and our instructions around this area. I thought it was standardized. It wasn't. We've gotten better at that. And then we started initiating postoperative nursing phone calls at 48 to 72 hours. And I think some groups are doing this, but we didn't have a routine, and it has been amazing. The patients love it, and we have learned so much in just a few months to find out what their issues are at 48 to 72 hours. And we learned what was working. We thought we had a good constipation regimen. We learned it wasn't so good, so we've made some changes to that. And since our nurses started calling in about November, we've had 0 readmissions. Now, I can't promise we're going to sustain that, but it's made a difference. And so it's been something that was really helpful and seemed simple, but made a difference. So has it worked? And we looked at, our program started March of 2016, and so what we did is we compared the calendar year before that to May of 2016 to May of 2017. We had a little washout period as we were starting the protocol and teaching everyone. We didn't want to overlap with that, so we had a 4-month break in between. And I'm not going to show the slides, but basically our case type and our patient demographics were really almost exactly the same before and after without it being randomized. It just happened to work out. And so I'm going to show you the specific outcomes related to our ERAS interventions. So first we looked at fluid balance. And as thoracic surgeons, we're already fluid restrictive, but we were that much more attentive to it, and we were able to substantially reduce our fluid balance for the entire hospital stay. The VATS patients are on the left and the thoracotomy patients on the right. The orange is the ERAS patients. And before our ERAS, before ERAS started, we used epidurals in practically every thoracotomy. And then after we started ERAS, we got it down to just 12%, and that's simply because it took me 2 months to get Exparel approved, and we had to use epidurals for the first couple of months of our protocol. And liposomal bupivacaine, we started using immediately for all thoracotomy patients as soon as it was approved, but it took me 6 more months to get them to approve it for VATS. They were very strict with us about that. PCAs we used for practically everybody before ERAS, and then afterwards we used it for very few patients, 17 to 20%, and I think it's even lower now. And I'm going to pause for a minute. This is the most important slide of my talk. This is our morphine equivalents. On the far left of each graph is the intraoperative use, and you can see it's almost nothing after our ERAS protocol intraoperatively. But postoperatively, we've reduced our narcotic use by 75% in the VATS patients and nearly 60% in the thoracotomy patients. Just to give you a frame of reference, a 5 milligram morphine equivalent is 1 oxycodone. So as you can see with ERAS, we're using about 10 or 11 oxycodone tablets for the entire hospital stay for thoracotomy patients. So it's a really huge change. And when we looked at our pain scores for the VATS patients, and there was no difference with this change, with a lot less opiates, and with thoracotomy, no statistically significant difference in pain scores with no epidural and substantially or 60% less narcotics. I know you can all see that the actual pain score is slightly higher in the ERAS patients than before. I'm not sure why that is, but I think patients were engaged in their care. They knew it was important not to use narcotics. And I think they opted sometimes to take less pills. I don't know for sure the reason, but people were happy with this and they had the option to ask for more. We looked at our length of stay, and while not statistically significant, we shaved a whole day off of our stay for VATS patients. We weren't expecting to even impact that. We thought it would stay at 3 days, and we got it down by a day. And for thoracotomy patients, we did achieve a statistically significant reduction in 2 full days in the length of stay. Our readmission rates were similar. That's something we're still working on. I don't think they're where they should be, but this is the first year. And then this was an unexpected result. We looked at our total hospital costs for before and after ERAS, and we had no idea we were going to have this degree of impact, but we saved over $5,000 per patient for VATS and almost $16,000 per patient with thoracotomy. For 139 patients in our first year, this was about $1.3 million in savings. And the other thing that got our administration's attention was that we saved 154 bed days with the length of stay reduction. And our average length of stay for any admission to UVA is 5.5 days. That let us admit almost 30 additional patients in 1 year by having an ERAS program, and that got their attention. So how did we do this? Well, I was lucky to have a great ERAS program before I got there in colorectal and gynecologic surgery, so we had a platform already. And I'm going to point out the person on the far right, Bethany Sorosiak, is absolutely the person who deserves the most credit for this. She's the engine behind all of this. But we had that platform to build on, and then our thoracic team was able to work with those existing infrastructure. And myself and Randy Blank, our chief of thoracic anesthesia, were sort of the physician leads for this. It took about 8 months of planning to get our program put together and ready. I hadn't even started at UVA, and I was on conference calls for probably 4 or 5 months before I got there. But we had something to start with, but we had to tailor the program to our thoracic needs. It's a very much a dynamic process. It's not what you start with is not what you end with, and it changes all the time. It was definitely a multidisciplinary effort. We included the pain service, we included nurses, a lot of people from different disciplines. We met and continue to meet at least quarterly, but I would say Bethany, Randy, and I talked all the time, emailed all the time, always in communication about this. And one thing I did that I think was really helpful is I personally went to the pharmacy committee to get the Exparel approval, and I brought them papers. I didn't delegate it to somebody else, and I think that helped a lot with getting that through the process instead of having someone who's lower level and not invested to go and ask. And I also have to credit, again, the MD Anderson group because I talked to them frequently about what they were doing so that I could implement it at my place, and it was great to have that mentorship. And we had to engage stakeholders across the hospital. So every phase of care that the patient interfaces with, they were part of the process. And not only to teach them about ERAS, but for them to teach us what was working, and then for us to re-educate them if they weren't following the protocol. But for sure, you have to work with people all through the system, and this is another area that our nurse, Bethany, was tremendously helpful. She would have huddles and emails and sessions with these people, and she still does it all the time to make sure that we're staying on target. Some other keys to success is to, again, if you're looking to start a program like this, probably most of you have enhanced recovery in other disciplines in your hospital, and work with those people. Find out how they set it up, find out what infrastructure they have and what you can share and what resources you can share with them. And I think as you're starting your program, you need to step back and think about where are the areas that you need to improve in your program, what are the problem areas, and make sure that you design your program in a way that you're going to impact those. And I say that because I've seen papers out there on enhanced recovery, and I don't want to malign anyone, but they talk about using a warming blanket and an optional 2.5-hour teaching session, and that's their enhanced recovery program, and then they say there's no difference. That's shocking. I'm surprised there's no difference with a warming blanket and an optional teaching session. You have to make sure that the intervention is actually going to do something and that you're targeting a problem and that the intervention is going to hit the nail on the head with that. You have to have physician champions. I can't emphasize that enough. And it really needs to be surgeons and anesthesiologists. And then if you can, try to get the resources for a nurse to help you, because I don't think I could have accomplished what we did without our nurse. And then you got to measure your outcomes for many reasons, not only to learn what you're doing, but then to take that information and go to your administration and ask for more resources. And you have to be open to the fact that there's going to be constant adjustments and changes. It's not what you started with. It's going to keep changing. That's a tenet of enhanced recovery, is that it's a dynamic process. In terms of the hospital administration, this is another Surfolio lesson, is you need to show the value of your program to the administration. So you have to have something to bring to them and talk to them about opioid reduction. They're all ears about this stuff now, I guarantee it. They want to know about readmission reduction, and they want to know about patient satisfaction. And try to get an audience with them. Now I'm getting an audience with them. I was able to get in front of the senior leadership a month ago, and I'm going to do it again, a different group of senior leadership in another month, because I have a bunch of things I want to keep doing with the program, and I need them to support it. But I've got the data to show them of what we're able to do. Where should you do this? In your hospital, of course. And when? The time is now. And I'm going to finish with this last slide just showing the opioid reduction, because again, I think this is probably the most impactful thing with enhanced recovery. And I think as surgeons, this is where we should put our effort if we're going to impact the opioid crisis. Thanks for your attention.